All right, good morning, everybody. Welcome to the EQUIP subgroup meeting. Um, it's been an exciting couple weeks in healthcare in Maryland, and this morning's meeting should give some interesting updates. And we're very excited this morning that we have a really important guest with us, the executive director of the HSCRC, John Crum, is going to give us a brief update on what is going on with everything, and particularly with the announcement last week. So we're going to jump right into deep water to start the morning, and I'm going to turn it over to John to give us an update on the ahead model.
Thanks, Gene. I think Gene and Krista and Olivia and others are very clearly the more important folks for this call. But happy to see everybody. Thanks for inviting me, and happy to give an update on the ahead model. And part of the reason we thought it was a good time to do that is because there was an announcement last week that was a little confusing coming out of CMMI. And so I just wanted to start with a clarification on what that announcement meant. So you may have read in a couple news articles or seen the CMMI announcement that announced essentially that the total cost of care model was planned to end. The context for that is that, yes, that is correct. And that was as expected, right? The timeline has always been, or at least for the last year and a half, right, that Maryland would transition from the total cost of care model into the ahead model beginning January 1st, 2026. And the two models were never intended to be run concurrently. So it was always expected that the total cost of care model would end at the end of 2025 and the ahead model would start for Maryland at the beginning of 2026. So what CMMI's announcement was that it was on the list of programs that were expected to end at the end of 2025. What was different about our program versus some of the other programs on the list is that there was a track or an intended path for continuation of the model just under the ahead model, right? So CMMI did come back and make and clarify that, right? So if you click on each of the programs, most of the other programs are expected to essentially terminate. Our program is expected to just morph into the ahead model. So they clarified that later in that day. I will also say that they reached out to us right before they announced it. It was a little bit of a surprise announcement. They kind of got scooped by some media outlets, which kind of rushed their timeline on the announcement. But they did reach out to me and a couple other folks just to clarify again what I just described and to express their intent to move forward with the ahead model. So all of that is positive, right? So they are again expressing their intent and commitment to moving forward with the ahead model. That is helpful for us in the sense that when we were negotiating the ahead agreement last year that we signed, EQIP was a really important part of that, right? So I think there was a lot of interest, especially on the part of the CMMI professional staff in seeing where EQIP could go. There's a lot of kind of interest and kind of positive kind of understanding of the EQIP program and the potential. So all of that is still exists, and we've not heard differently. Obviously, this is not without risk, right? We know that CMMI is likely to look for changes to the ahead model. We don't know what those things are. We will kind of try to keep everybody in the loop as things progress as to what those might be. But just to, again, to clarify, especially with regard to EQIP, we have not heard anything that would suggest that EQIP is changing or being cut out of the model, and that CMMI has again expressed interest in working with us in continuing down the path toward ahead. So let me pause there for a moment. Any questions from the group? Okay. Obviously, lots more to come here. Um, we will keep this group updated. We are working with a number of stakeholder groups to make sure that everybody is kind of up to date. And this is such a complicated model that we want to make sure that um, we are staying as connected as possible to all the many, many people who make the model work, like yourselves in the state. So let me pause there. Gene, anything else to add?
No, I just want to thank you for coming on this morning and giving us a
So
couple minutes. And really appreciate your willingness to talk to us. And it shows the importance of equip to the HSCRC, and we appreciate that. So we will let
I
you.
have a
Oh, go
question.
ahead,
Good morning.
Dr. Zama. Go ahead.
I'm sorry, I was trying to unmute. Now that with CMMS, as you mentioned, that the carrier folks are probably going to want to keep things the way they were as was negotiated. But as we see with Dodge and the Trump administration changing everything, what makes you so confident that nothing is going to change?
No, so Dr. Zama, to be clear, uh, we don't know that nothing is going to change, right? In fact, we expect that they will look for changes, and so we will keep everybody up to date on that. What I'm saying is we've had no indication that EQIP is something that they want to change, right? So we are keeping a close eye, and we will be engaging more deeply with CMMI. I would characterize where CMMI is in this moment as this is a complicated model. They've spent a lot of time kind of getting their political leadership, who kind of landed fairly recently, to wrap their heads around all the many programs within their portfolio, this being one of them. And so they're still organizing on their end. So to your point, I don't want to give the impression that there's like no, that we're confident that nothing will change. What I'm saying is we don't yet know, right? We'll keep this group and others up to date as we get more information. But again, the momentum for EQIP is high because I think there is a lot of kind of positive feedback and positive sentiment around EQIP and EQIP's potential moving forward. I mean, that's true on the state side as well. Obviously, I think you know that everyone at HSCRC is a big supporter of EQIP and believer in its potential. So,
And
so I
Equip
just
has been and Equip is embedded in both contracts. It's in the total cost of care contract the state has with the federal government, and it's also in the AHEAD contract. And in both years that we have performance for Equip, the quality measures showed incredible improvement for patients, and we had cost savings both years. So it's really kind of hard to argue about Equip. So that I think is the point that's being made.
it's got a
Thank you
very
very much.
good story. It's got a very good story. Yeah. So
All right. Anybody else have any questions for John? All right. We will let you get back to your busy day. Thank you so much for taking a few minutes to talk to us this morning.
great. Thanks, everyone.
All right. So now I'm going to turn the meeting over to Kim. And I did just want to say before I did that really quickly, Jessica Hayslip did an amazing job for us for the last few years. And she got a great promotion, and she's doing a lot of neat new stuff at Chris. But I just want to take a second, and thank her. And Kim, if you could let everyone know that everybody on this committee really appreciates everything she's done for us and all the help. She's been terrific, and you have big shoes to fill. But having worked with you on the transformation grant and some other things over the last 6 months, I know you're going to do a great job too. So I will go ahead and turn the meeting over to our new manager from CRISP, Kim Dixon. Kim, it's all
Thank
yours.
you. Thank you. Absolutely. We'll pass that along if Jessica's not on the line. And yes, you are right. I do have some very big shoes to fill, but good morning, everyone. I am Kim Dixon. I know I was sort of introduced at the last subcommittee, but I just wanted to remind everyone that I have stepped in as the program manager for EQIP, and Jessica Heslop has transitioned to a whole new department inside of CRIS. And so she's no longer managing the EQIP program. So for any questions or support that you may have or need, please reach out to the equip@crisphealth.org email inbox. This ensures that you will get a timely response. If you email Jessica privately or only Jessica, essentially she's so focused on her new role that your email may get delayed in getting some answers, and we don't want that. So just be sure to email the EQIP inbox. Myself, Crystal Fort, we are both inside of that email box multiple times a day, so we will get your question answered as quickly as possible. And with that said, I am very excited to collaborate with all of you to ensure the continued success of this EQIP program. Now, I'm going to turn this over to Crystal Fort, and she's going to walk you through what's getting ready to happen with the CRS migration over into the Crystal portal. Crystal? You might be on mute, Crystal.
Can you guys hear me now?
Yes.
Okay, sorry, must have been my headphones. Hi everyone, so I'm Crystal Fort, and thank you for that intro, Kim. So we're just gonna quickly go through a couple of updates. So essentially, there's going to be a little bit of a change during this enrollment cycle. Typically, for enrollment, you guys access EQIP or EAP through CRS. And so that will be migrating to the CRIS portal. So this means that you'll no longer be accessing EAP through the reports.crisphealth.org, but rather portal.crisphealth.org. So in lieu of this change, we're just going to do a quick demo of how users will be accessing EAP come enrollment on June 30th for this upcoming enrollment cycle. So essentially this page that you're looking at right now, this is what you'll see after you type in portal.crisphealth.org. So you'll be asked to log in with your CRISP username and password. And once you've logged in, you'll be routed to the CRISP portal, which is this homepage that you're seeing. On the bottom of the homepage, you'll find a reports tile, and that's what I have highlighted here in red. And you'll click on that tile and you'll be routed to CRS reports. You can go to the next slide. And once you click that, you'll find this page that's being shown here, and you'll then click the Medicare population tile, and that will take you to the EQIP entity portal link, which is on the right of this slide. And if you go to the next slide, you'll then be routed back into EAP. So this is a page I'm sure a lot of you all recognize. And I do want to note that this feature is currently being completed by our technical teams. So if you try to attempt to access EAP through the portal prior to June 30th, you may not have the reports tile provisioned to you as of yet, or you may see some of the headings that I have highlighted here in red, the PY4, the unenrolled, or the enrollment is closed. That's just because all the transitions haven't been made as of yet. So we're working on that. And so since there's no cause for alarm or anything, since the migration is still actively happening, you can go to the next slide. However, we just want to ensure that all the current participants who are enrolled right now for PY4 are prepared in time for enrollment. So the EQIP team will be sending out emails in the coming weeks to just confirm CRIS portal access. When you receive this email, please, please, please follow the instructions that are attached to it or respond if you have any questions. This is just to ensure that come June 30th, everyone is prepared to be able to log into the CRIS portal. So please respond to the email just so that we can make sure that your access is all set up and ready to go. And we just want to make sure that everyone has a very seamless enrollment experience. So again, just please make sure to follow up on that email that you'll be receiving probably in the next 2 weeks. But that's all for me. And if you have any questions about this, feel free to raise your hand or you can email us at equip@crisphealth.org.
Okay, Crystal, we have a couple of questions in the chat. So the first question is, if I have the EQUIP entity portal saved as a favorite, will I need to access via this new process? Yes.
Yeah, so when you go to the portal and you're routed to the reports tab and you click it, it essentially is just routing you to what CRS used to be as its own separate website. Essentially, we're just conjoining it. So there is no two separate houses for one for eQuip and one for Chris Portal. It'll just all live in unison. So when you do go to the reports tab, excuse me, in the Chris Portal, and you click reports, and it'll route you to the eQuip entity portal because that's already saved as a favorite for you. So you'll be good to go there. And I see there's one other question. Is there a bulk enrollment option? Could you further explain what you mean? Do you mean if you're currently an entity or if you are enrolling for the first time?
Well, I think whether you're a new entity or whatever, I think every time you have to put all the people in independently. I don't think there's an ability to upload like an Excel spreadsheet, is there? Or if there is, I guess the question is, will that continue?
I mean, all of the actual processes will be continuing. The e-portal is not changing at all. It's just the process to get to the e-portal that's kind of changing. So I believe there is a feature where you can upload an Excel file of the NPIs that you'll be participating with. I can confirm that, but I believe there might be an option to do that. But if not, then you would have to default to just individually adding them. But I want to say
Yeah,
80%
I'm pretty sure there is.
I'm pretty sure there is. Yeah.
Yeah.
Mhm.
So.
I think the first year I helped do some with it. I don't think I did last year. I think we made Olivia do it. But anyway.
But yeah, if there's any more questions, please feel free to put it in the chat, or if you think of any later, feel free to email us at equip@crisphealth.org.
And
Thank
I
you.
think we're going to do like a special webinar later on,
Yeah.
Yeah.
maybe Crystal, you and Olivia, or something, just kind of going through the portal. And once it's up and running and showing people how to use it, right? We'll do like an educational video or something.
Yes.
Yes, I
Yep.
believe that's scheduled for, Kim, correct me if I'm wrong, June 19th.
Yeah.
Yes,
Okay.
we will be doing that as well, and that'll kind of do a more in-depth demo of everything that you'll have to do in order to enroll or re-enroll for this performance year.
So no worries there. We're just bringing this to your attention. We will definitely have more information for you as we get closer to our enrollment date. Thank you, Crystal. Okay, moving on, data release schedule. So, as you know, all data release dates are subject to change, and we currently have a change in our baseline PY4 data. So that was actually supposed to have been released a week or so ago. And we've had to put a pause on that because the data team has found some discrepancies in the data and they're trying to work through all of that. The hope is that we will get this data uploaded within the next few days. I'm thinking early next week. But again, don't hold me to a specific date just yet because the data team is actively trying to work through this issue so that we have the most accurate data available. With that said, this also then pushes back the PY3 Q3 data, which would have been coming out at the beginning of April. Now we're looking at mid to late April before that information comes out. Okay. Everything else looks to be staying on track as far as data releases are concerned, but I just wanted to call your attention to those two items. All right, episode development. Okay, so right now we are in the middle of still doing our assessment on all the new episodes that were asked for PY5. So we have pushed out the recruitment and episode education to early summer of 2025. So we'll still have all that information before the actual open enrollment begins. So you'll be able to have, an honest, clear idea of what the episodes are, and you'll be able to select from there moving forward. But I just wanted to show you that our timeline was just adjusted a little bit, okay? So currently we have 76 new pieces of episodes of interest. As I just said, we are currently going through the assessment of these new episodes to ensure that they are in alignment with the EQIP goals, that they meet the volume requirements. We have 9 new episodes that are in development that have been requested, and we're leveraging PACES to expand our episode catalog. So once the assessments are finalized, we will provide you with a complete update on the PY5 episodes. And also just to reiterate that we plan to leverage the extensive PACES episode catalog to continue to add episodes for future years. Here, for the next 2 slides here, you're going to see the current PY4 episodes, which are highlighted in blue. And then the ones that have been requested for PY5, these are just have the plain white background. Again, this is not a final for PY5, but just to let you know where we're standing as of now. And you can certainly go through this when you get sent the slide deck and recording after this meeting. And again, any questions on that whatsoever, please feel free to email us at the EQIP inbox. Okay, moving right along. EQIP Practice Transformation Grant. So this program has actually been delayed right now, unfortunately, and it's due to the recent federal policy changes. As of now, we do not have a revised timeline, but we're staying in close contact with CMMI for more guidance on this. All participants that were approved to participate in this program were notified via email on February 25th. So if you have any more questions or you need any more information, again, please do not hesitate to reach out to the EQIP inbox. Now, with that said, I'm going to hand it over to Krista Spiker to talk about the rebasing. Krista?
Hi, great. Thanks, Kim. I'm Krista Spiker. I'm the Deputy Director for Payment Reform at the HSCRC. And we're just going to do a quick discussion on rebasing in EQIP. So as folks know, the current EQIP baseline period is 2019. We've had several discussions with stakeholders and received input, around considering updating the baseline. The baseline period will be 7 years old for performance year 5. And so we were, trying to figure out if maybe considering a new baseline would be an appropriate change. Also, there's provider churn, influx of new providers, the availability of post-pandemic data. And there were other program design considerations that we took into account when having these discussions. Another important piece of this is that AHEAD uses a 2023 baseline. So we were considering all of the factors at play, but we made a decision with significant input that only the ED episodes will use 2023 as the baseline period in PY5 and moving forward. And we'll continue to have these discussions, especially as things evolve with AHEAD. And we will not make any changes, again, without significant stakeholder input in terms of changing the baseline in the out years. But for now, just the emergency department episodes will use 2023 as a baseline period, again, in PY5 and moving forward. If folks have questions, please feel free to put them in the chat, or I'll take questions now. Or
quick question on your bullet on provider churn. It says that there are other policy changes that could address the 75% of providers. Can you talk a little bit about that in light that only ED episodes are going to change the baseline going or in the immediate future?
Yeah, so I don't know. I wasn't really a part of this discussion exactly. I don't know if other folks have input on this. We contemplated a change in the 75%, and I think that's something that we would be open to discussing in the future, but we did not make a change to that for this period. I think I'm not really sure what the other policy changes are, to be honest, but I can certainly find that out, how we could address that. I don't know if there's anyone else in the line that could address that.
I think the issue, I was in some of the subcommittee meetings. I think the issue was if you don't make changes, if you're going to keep the policy the same, it was hard to monkey with one part of it and not the other and deal with everything.
Right.
Like the thought process. But let me also say this. One thing we might want to consider doing, if you know for a fact that you have practitioners who are outside of baseline, maybe we can try a few months before enrollment to see if we can find equip entities that have space for them possibly. And maybe we could think about how we set the equip entities up so more people can participate. I do understand it's a problem. And essentially, I think the decision was we wanted to see what would be the outcome of changing baseline, and the emergency folks requested
Right.
specifically to be changed, and this gives us a pilot. And
Yeah, exactly.
before we make a change like this that could, disrupt the whole program, and since we had a group that was excited or interested in making that change, we went ahead and did it. So we just want to be cautious and not mess up something that's working and is good. Do you know what I mean?
Absolutely. And I totally agree and appreciate that. Just, I think that is kind of one of the lingering questions for us, but we'll
So Katie,
just
but
keep that in
maybe you can just reach out to Olivia or I, and we can try to figure out if there are entities that have space for practitioners who don't meet baseline. Obviously you can maximize out at your 75%, but maybe there's a possibility we can find another entity that would be willing to partner with you. And one of the things that's great about Equip with the entities, if we can have different practitioners, hospital-based and private-based, working together in some fashion, that's a positive. That's the kind of thing the model wants. So maybe we can have the discussion and see if that can be done to solve the problem. Okay.
great. Thank you, guys.
Yeah. Thanks, Jean. And I think I'm going to turn it back over to Kim.
All right. Thank you. So now we're going to move on to quality metrics. So currently, we all know that the quality metrics for PY4 is the NQF 326, the Advanced Care Plan, the NQF 419, which is the documentation of current medications in the medical record, and then the MIPS 128 body mass index BMI screening. So we are looking to replace the BMI quality measure for PY5. So PY5 currently looks like we're keeping the advanced care plan. We're also keeping the documentation of current medications, but we're proposing the possibility of replacing the MIPS 128 with the CMS 165 version 11, controlling high blood pressure, and the CMS 122 version 11, diabetes, hemoglobin, A1C, poor control. That's the inverse measure. So these measures we feel like align with EQIP's focus on improving the care outcomes and reducing costs. We will have a finalized listing of these PY4 quality metrics before open enrollment begins. But if you have any questions on how to track or report, you don't really report these measures, but how to track them, how to code for them, etc., please feel free to reach out. So I'm going to open it up to any questions for any of the topics that we've discussed so far today before I move forward. Looks like we have a couple in the chat. Let's see, Maggie Smith, Krista says, we're supportive of changing the 75% requirement. We have lots of providers that aren't able to participate due to this requirement. Ashley Perkins asks, how do you support specialties that don't engage on these things routinely? Oh, regarding the quality measures. Well, that's a really good question. I think that most providers would be, should be documenting all of the current medications in the medical report. So there is that. You also have to remember that these quality measures don't just lie solely within the providers that are seeing the patients. These are claims that could come in from any provider. So if they are seeing their PCP, then a lot of these might already be covered. If you're seeing a patient, even as a specialist, checking blood pressure, and if you know that they have diabetes, making sure that they have an updated A1C is probably pertinent as well. So again, if you have any other questions on like how we can track for that, I'm happy to have those discussions independently.
Yeah, just one of the points I would make, MedChi has these entities where we're trying to group people together so they can participate. And for example, ophthalmology for end of life, which is one of the current quality measures. When you go to your eye doctor, you don't want to have a discussion about end of life. That's not something that's exciting, and eye doctors aren't used to having that discussion. So it's kind of a current problem. I think the key is that the entity that's helping the practice, or the practice if they're doing it themselves, really needs to figure out how best to coordinate with the other practitioners or somebody else. And I definitely think it's a really good point, Ashley, because obviously in the care setting, a lot of these things are not done at that point of service. So it's really about finding out how we can work with other practitioners to make sure those are achieved during the time period of the bundle. And back to the baseline, there is a small group working on that. I saw the other comment. Anybody else who wants to have a discussion about that, I think everybody would love to change the percentage. The issue is if we change the percentage, are we going to be required to change the year as well? And that's more complicated. So I'd love to have discussions with more people about that and how we do that.
Yeah, and Jean, I want to just say that we are totally open to that discussion and happy to continue that. So I don't want folks to think that's, something that's been decided and we can't address that. So yeah, thanks for offering that up.
Marianne, I see your comment in the chat where you say the CMS 122 hemoglobin A1C as an inverse measure is cumbersome to measure and report on. So reporting is really, remember, it's all claims based, and we can certainly create a one pager to send out to everyone that will give you the specific codes, G codes, CPT2 codes, etc., to help with that moving forward.
Yeah, so one of the things I think one of the things that when we developed this, whatever it was, 6 years ago, we really fought hard to have the claims-based quality measures because that's a lot easier for practitioners generally. And I understand your point that particularly if you're a practice where you're not used to billing these particular CPT codes or these modifiers, it does take some a little bit of redesign, but we will, and we did it with the other three quality measures. We had really nice one pagers. CMS has some one pagers as well, but we'll put some stuff together so we can figure it out. The nice thing is this is a lot less burdensome to bill 4 or 5 CPT codes or 4 or 5 modifiers than it is to bill to do MEPS. So it really is a savings of time and energy for the practitioners. So if you have ideas or concerns around them, we're happy to hear them, and we have people at CRISP and MedChi who are happy to help you try to be successful with regards to that.
Exactly. Thank you, Jean, for that. Are there any other questions? Go ahead, Maggie. I see you have your hand raised.
Yeah, just wanted to make a comment about replacing the BMI measure. I think that's great as it's being suppressed in MDPCP in any way that we can kind of align quality measures with AHEAD coming down the pike with primary care AHEAD and the Medicaid program would be super helpful.
Thank you. Thank you for that comment. Ivan, I see your. I'm sorry. Go ahead. Who's talking?
No, go ahead.
I was just going to say, I see that you get a lot of denials on the CPT codes for advanced care planning. I'd be interested to see what sort of CPT codes that you are entering in. Again, we have a one pager on that we can certainly send out to you. But we're all of us are definitely happy to help you in any way that we can with that. Did that answer your question?
Yes, ma'am. Because actually, I got to the point where my biller has been suggesting that I shouldn't use the codes for advanced care planning, which is the 99497 and 99498. So
Okay.
I was kind of curious if that is a good idea because my documentation is strictly advanced care planning why should I use prolonged service codes?
That's a good question. I'm not a specific coder, so it's a little hard for me to discuss that with you, but I can certainly dig into that and get you some more information. Jean, were you going to say something?
I was going to say maybe Olivia, you can have Kem from MedChi meet with Dr. Zama and see if we can't get an answer on that. The one thing I will say, Dr. Zama, it's really important to make sure that your biller understands which codes are required to meet the quality measures. And there's a really nice list. There's good information on the CRIS website, and Olivia can send it to you, that kind of shows exactly what counts towards the quality measures, what modifiers and what codes do. So make sure your biller understands that when they're giving you advice. Dr.
Thank
Motor.
you.
Good morning, thanks. I was just wondering if we could, and you might have already said this, I missed it, but why did we remove documentation of current medications in medical record? And I only bring that up because that seems to cross all specialties that we should be reviewing people's med lists. And it is definitely an area that we see repeated errors in. So, by looking at this, it looks like it's not being carried forward. We're replacing it with controlling high blood pressure and diabetes. Is that correct?
No. We're keeping the advanced care plan. We're keeping the documentation of current medication. We're only replacing the BMI.
We're replacing it with the high blood pressure and diabetes?
Yes. And
So
it's just a proposed measure at this point. Nothing has been settled.
So we're replacing one with two additional?
Yes.
Okay. Thank you for the clarification.
You're welcome.
And I'm glad you're keeping medication reconciliation. I think that's a big deal.
That's huge. I agree. Dr. Gruner, are there other measures to consider? I know for a lot of specialties, BP and A1C are not routine items in orthopedics. We should discuss other options if you are open to it. I'm going to leave that for Krista to answer.
Yeah, thanks. I think we just a little background on the process, and again, I think we're always open to considering options outside. We did have a formal technical advisory panel that with representatives from orthopedics and cardiology, physicians, nurses, etc. And we feel like we've come to a place where these are the most appropriate measures. I think if you have ideas, please feel free to send them to Jean or Kim or myself, and we'd be happy to have a conversation. We went through a very thorough process and kind of came to a consensus around these, but certainly if you have ideas, I think we welcome them. We would like to make decisions about these in the coming weeks so that we can ensure that they're in place and for the upcoming performance here. But please let us know, and maybe we could even set up some time to chat on the side, you, me, and Kim. We can get your thoughts, but.
And it's always a balance, Dr. Grunner, between simplicity and complexity. And obviously, it might make sense to have different quality measures for each bundle based on which specialty is going to do it. But the problem with that is it makes it more complicated on the back end, right? So I think we're trying to err on the side of making it easy. And particularly given the fact that a large number of the folks that are helping do this are helping with multi-specialty. So if you're a large hospital system with a big practice that's doing this, they're going to try to implement these measures across the practice. If we were to have those groups have to implement 20 codes, 3 for each specialty, it just adds to the complexity of that. So while I think we're open-minded about it, one of the beauties of this is the fact that it is claims-based, which is a lot easier than EMR or MIPS reporting, and we want to try to keep that simplicity. And while it's simple, these are really important measures that help improve the public health of Maryland. So we're trying to keep that balance, and that's what we've been struggling with from a policy point of view, if that makes sense.
No,
Victoria.
makes sense. That makes sense.
Sorry, go ahead. Go ahead, Dr. Bruno.
No, that makes sense. I might touch base with you guys on some other options that, but it seems like you guys are pretty far along in the process here.
Happy to talk with you, Dr. Victoria.
Good morning. Just regarding the quality measures, was this something in terms of like replacing the BMI quality measure with the high blood pressure and the diabetes that gave consideration to the specialties? I know that Jean was just mentioning how it's a more holistic transition in terms of trying to improve the public health of Medicare patients in Maryland, but it just seems like the high blood pressure might be an easier measure to track on for the practitioners that are participating in these EQIP entities and diabetes, depending on what specialty they're in. So was there consideration about kind of like who was actually enrolled in the program when the decision was made to transition from one of the quality measures to the high blood pressure and diabetes?
There was, as Krista Spiker had said, we had a group of individuals. We pulled in cardiology, orthopedics, a bunch of different specialties, and we had multiple conversations with them, and we reviewed a significant amount of different quality measures, and these were the ones that pretty much everyone within the group stated that they felt were important measures to be monitoring across specialties.
Okay,
Yeah.
thank you.
And I'll just add too, I think the experts that we engaged with were not participating in EQUIP because we felt like they had more of an objective sort of perspective, but also understand the, how these practices work and sees between the specialties. So again, welcome feedback, but that's if folks are like, well, I didn't have input. We really tried to engage folks with an objective perspective, but happy to take your feedback as well, which is why we're presenting these today.
Okay, thank you so much.
Welcome.
And Krista, when will the final decision be made on what the measures are?
I would say, in hopefully in the coming weeks, we'd like to make a decision in order to operationalize everything. Does that sound about right, Kim?
Yeah, definitely.
Yeah.
We wanted it obviously before the open enrollment begins for PY5 clearly, but the sooner the better. Yeah.
Yeah. And maybe the best way to do it is so we have like clear feedback from folks is to submit to the mailbox. I mean, certainly reach out to Jean, reach out to Kim, but I think that way we can take, action and feedback in a more kind of organized way. That would probably be the best way to approach this. But
Agreed. Dr. Mattermass, I have your comment. It says if we were to select one of the two, controlling high blood pressure seems to be the easiest for everyone. We definitely will take that feedback. But also just remember, diabetes, the CMS diabetes measure, this isn't obviously for everyone. You're not going to ask every single one of your patients if you know they don't have diabetes. That's not going to be an issue. But again, these are things that everyone on the committee felt were important, especially if you're doing procedures and things of that nature. Michelle, how would it be captured? High blood pressure, it's generally not a claim with measurement unless there's a Z code. There are codes, and I do have those available and can certainly get those out to you. You're welcome. In fact, it might actually be, I wonder, Jean, tell me what you think. It might be better if we kind of put that on maybe our website and can also be put on the MedChi website for EQIP as well, just to have that listing.
Yeah, we'll put them both out, and maybe if we get something together,
Perfect.
we can send something out to the group so they can see.
Yeah.
And it'd be helpful if when we send out, particularly the new ones, you've obviously been doing the old two, so that you know how to deal with those, or you figure that out. If you talk to your billing people and they say, "Hey, this is going to be a problem because of X, Y, or Z," let us know that right away, so then change will be made. But and make sure it is operational.
That's the goal. To try to keep it as easy as possible for everyone. All right. Any other questions? Well, we had a great conversation here. So with that being said, that wraps up our presentation. I want to thank every one of you for joining. And again, like I said, we appreciate your continued commitment to the success of EQIP, and I look forward to working with all of you.
One last announcement. The Maryland Healthcare Commission has a small number of slots left for their transformation grant, which is still open. If you know anybody who has not done EQIP who would like to do that, please reach out to Olivia or myself and we'll get you guys connected up with them.
I would love to.
Okay, well, Dr. Zama, we'll follow up.
Yes,
Any other?
I'm working on it already.
Great.
Wonderful.
Any other questions for the good of the order? All right. Well, great job on your first meeting running the show, Kim.
Thanks. Appreciate that.
Everybody have
Everyone
a
have a
great
great
weekend
day.
and go Maryland Terps this afternoon.
Likewise.
Bye-bye, everyone.
Bye-bye.